Good evening. My name is Emma Ellison. I'm the Clinical Education Account Manager at Performance Health. Welcome to tonight's webinar. As a leading supplier of hand therapy products, we are committed to providing clinical education and are delighted to introduce tonight's topic on wrist and forearm stiffness. I would like to begin by acknowledging the Bunurong people, traditional custodians of the land on which we gather today, and pay my respects to their elders, past and present. I extend that respect to Aboriginal and Torres Strait Islander peoples here today. You will have the opportunity to ask questions by using the Q&A box to type in your questions at any time during the presentation. We will collect and address the questions during the Q&A session at the end of this presentation. Tonight's webinar is being recorded and you will receive a follow-up email within 3 business days with a link to review the recording. I would now like to introduce our speakers for tonight, Jeff Sanderson and Brodwen McBain from Upper Limb Co. Jeff and Brodwen are experienced hand therapists with extensive experience in treating wrists. They are well-known presenters within the Australian Hand Therapy Association and have presented papers at national and international conferences, as well as writing and presenting courses run Australia-wide. They are both well known for their award-winning splint design of the 180-degree pronosupinator, which won the Australian Physiotherapy Association Pitchfest 2019 and will runners-up in the International Federation of Societies for Hand Therapy Innovation Award. Jeff and Brodwen will present an evidence-based look at the pathomechanics of wrist and forearm trauma that leads to stiffness, pain, and dysfunction. They will discuss practical solutions for prediction, prevention, and treatment. Thank you very much for being with us tonight, Jeff and Brodwen.
Thank you, Emma, for the kind introduction. Jeff and I are really happy to be here today. This is a real area of interest for us, and we want to thank Performance Health for making today happen. Before we start, we just want to declare the conflict of interest being the 180 pronosupinator brace. But as Emma said, today is more about general wrist and forearm stiffness. So I'll just get this PowerPoint going. There we go. So we have quite a lot of content that we're hoping to get through tonight. What you will find in the PowerPoint is that there will be details on the slides that we don't necessarily address directly tonight, and that's been a purposeful decision because we'd really like the PDF of the slides to be a useful resource for you down the track. So we tried to put in as much information into that as we can. But what it means is that tonight there'll be certain sections that we move through quite quickly, and then some other sections that we slow down and take a little bit more time and go into more detail with. So we'll start with a brief introduction to the movements of the wrist and forearm, and then I'm going to hand over to Jeff to talk about the stiffness aspect. So as you can see in this video, and as you may well be aware of, as we move into supination and pronation, the ulnar bone stays relatively still, and it's the radius that rotates around the ulnar. And it's both the proximal and the distal radial ulnar joint that allow that movement to happen. The proximal radial ulnar joint is not something we're going to spend a lot of time talking about today. We think it's better fit into an elbow-specific presentation. So instead, we're just going to briefly mention it as it may be a contributor to stiffness into supination or pronation. So just so that you're aware, and if you have someone who has an elbow injury, say a radial head fracture or a terrible triad type injury, this would be more likely to be a contributor there. The firmness of the infill is not always an indication of a bony endpoint in the proximal radial ulnar joint, and it's also a joint that's at risk of heterotopic ossification. Sorry, just a little lag on moving forward with the PowerPoint. There we are. So moving down to the distal radial ulnar joint, the key thing here is looking at the amount of movement of the radius relative to the ulna. So if you look at the bottom right-hand picture there, which is the pronation position, you can see that the radius is lying over the top of the ulna. And then if you look at the position of the radius in the supination position, which is on the left-hand side of the screen there, you can see that it's really moved right to the other side. So when we talk about pronation and supination, we're not talking about a small glide of a joint, we're really talking about quite a large arc of motion. So traditionally, functional range has been considered 50 degrees in each direction. What we find clinically though is often patients are unsatisfied with 50 degrees of movement, and there's a few reasons for this. One is that for much of what we do, we need more than 50 degrees. So for example, typing on a computer, you need more than 50 degrees of pronation. But the other aspect of it is if 50 degrees is your maximum point and you need 50 degrees for function, and every time you move to that point, you'll be feeling stiffness, tightness, perhaps a little bit of pain, and it's hard work. So what we'd encourage you to think about is not only the range that they need, but consider any range and reserve. So if they need 50 degrees, can we get them to 60 or 70 so that they're comfortable at 50 rather than really having to push to that point? So looking at supination and looking at the soft tissues around that, as you move into supination, the palmar radioulnar ligament tightens. As you get beyond 70 degrees, the radius actually dorsally translates relative to the ulna, and the soft tissues tension changes. So as you get beyond 80 degrees, it's actually the dorsal radioulnar ligament that tightens along with the palmar capsule. When we have supination loss, which in isolation is more common than pronation loss, it's really the viscoelastic properties of those soft tissues that are more likely to be the limiter rather than any bony malunion. And Jeff's going to talk about some of the bony malunion later on. So here are just some examples of some common activities that people require more than 50 degrees of supination for, and things that people often refer to as what they're aiming to get back to. For pronation, it's similar to supination, but in the opposite direction. So in the earlier parts of pronation, it's the dorsal radioulnar ligament that becomes taut, and as you get beyond 60 degrees, the radius again translates, but it translates in the palmar direction. And again, as you go further, it's the dorsal capsule and the palmar radioulnar ligament that become taut and perhaps your limiters of movement. Pronation loss, again, is less common in isolation compared to supination loss. And again, the soft tissues are more likely to be the limiters of movement than malunion. So again, here are some of the common pronation activities that people report needing more than 50 degrees for. With driving, it may be that they need easier motion or need to make driving easier or more comfortable with beyond 50 degrees. So moving on to wrist flexion. The question mark around its importance is really because often patients will come in and report that they can't move as well in a flexion direction. But really, when it comes to function, this is one of the least important movements to regain. So patients use this, but as clinicians, we may need to prioritise some of the other movements beyond this. The movement comes from both the mid-carpal and the radiocarpal joints. Normal range is approximately 80 degrees, but functional range is considered to be 40. Extension, much more important functionally than flexion. Much of what we do with our hands is in relative extension. Again, it's a combination of mid-carpal and radiocarpal joint movement, but in extension, it's more radiocarpal than in flexion. The other point of note with extension is that passive extension is actually quite important functionally. So if we think of passive extension, whenever we push down on something to get up or push on a door, we're going to move into some passive extension. So when we're looking at range of motion, compared to flexion, where you don't do much in passive flexion, functionally, we need to consider both active and passive extension. So this video shows that radiocarpal and midcarpal joint movement. You can see as they go into flexion, that midcarpal joint movement is nice and clear, and extension, that radiocarpal joint is more obvious. So midcarpal joint there and radiocarpal joint there. And this video is going to show radial and ulnar deviation, so radial deviation and then ulnar deviation. When you go into radial deviation, the proximal carpal row flexes, and you can see that in the scaphoid there. And ulnar deviation, the proximal carpal row extends, and both of those movements have that lateral translation. So radial deviation, normal movement is considered to be 20 degrees and functional movement is considered to be 10. With ulnar deviation, normal movement is considered to be 30 degrees and functional movement is considered to be 15. With ulnar deviation, ulnar carpal abutment can be a limiter of that range of motion and can be a contributor to pain. From a soft tissue perspective, the constraints of movement with deviation are very similar or overlap with the constraints of movement for flexion and extension. So when you have limitation in one direction, you're likely to have limitations in other directions as well. Equally, as you work on and improve flexion and extension, you'll get some improvement in ulnar and radial deviation at the same time. So the other movement to talk briefly about is dart throwing motion. And for those who work in hand therapy specifically, you would be fairly familiar with this. For those who don't, it's a combination movement, of wrist extension and radial deviation and wrist flexion and ulnar deviation. And it's considered quite a functional movement. But for the purpose of today's presentation, we're not going to talk about dart throwing motion. We're going to stick to flexion and extension, deviation, supination, and pronation. So here is some measures of what's considered functional range for specific function in flexion and extension on the left-hand side and ulnar and radial deviation on the right. Again, we just want to highlight that what is considered functional and an acceptable amount of range to regain is quite individual to the patient. And what is considered functional from a literature perspective may not be enough for your patient to function comfortably. Some of the activities on the screen here are things that you do multiple times a day, every day. And if those things are at your very end of range, then we need to consider getting a little bit more so that people can perform those functions comfortably rather than with effort or with tightness or discomfort. So I'm going to hand over to Jeff now, who's going to talk about stiffness.
So before I talk about wrist stiffness, the thing that we need to talk about is finger stiffness. If a patient attends and they're obviously attending for a wrist injury or wrist stiffness, if the fingers aren't moving and it's heading to a time critical point, you really need to prioritize the fingers. There's a few reasons for this. If it's 6 to 8 weeks, they've just come out of a cast or something like that, and the fingers are still stiff, well, that's really tough to resolve. A month or two of fingers not moving, really, really tough to get full movement. A month or two of a wrist not moving is quite resolvable within some difficulties that we'll talk about. Functionally, you can't even think about getting them using the hands if they've got no fingers. And the wrist, if it's stiff, they can still compensate, still get the fingers and the hand into space for some limited grasp and function. So really, you've got someone who's got both finger and wrist stiffness. You've got someone who's possibly not coping and is certainly not going to cope with a really significant wrist and finger program all at once. Fix the fingers while it's time critical. Come on and get the wrist going secondarily. So once you see finger stiffness, stop. Sort the finger stiffness out and move on to the wrist. Of course, for most patients, that's not a problem, but it's something you should be aware of. You don't want to bite off more than you can chew, and you don't want to be doing far more than is practical for a patient. So we're going to be talking about conditions that cause either forearm, as in rotation, pronation and supination, and wrist stiffness today. Very much from a trauma and orthopedic perspective, and the bulk of the literature and the bulk of the cause of this is going to be distal radius fracture. The other things listed will be discussed, but there's far less literature for many of them. And of course, for things like burns, crush, and neurological conditions, that's well beyond the scope of tonight's discussion, unfortunately. So the reason we're going to talk a lot about distal radius fractures is it's really common. It's the second, or depending on when you survey, first most common fracture. 10% of women over 65 will have a distal radius fracture at some point. It's not perfectly homogeneous as a condition. It's bimodal. So we have younger people in their 10s and 20s getting it from high speed sports or trips or whatever else they might be doing in a hurry. And then of course we have the over 65 population where the bones tend to be a little bit more osteoporotic, which is why women get more of them than men. And there tends to be a slower speed fall that causes that. They're slightly different injuries, but often categorized together. It's a heterogeneous injury, so it's got heterogeneous outcomes. Most people get really good outcomes, fairly straightforward. For those people, they can switch off now. They don't have complications and they don't need too much therapy. Certainly nothing too complex. So for the complications, they range somewhere between 10 and 30%. Somewhere around the 20% is pretty common for something like stiffness, which is the most common complication of distal radius fracture. There are a few others listed there today, which we will not be covering. And of course, you can see the AO classification at the bottom. You can see there are dozens of ways you can do a distal radius fracture, plus or minus the ulnar and other associated injuries. They can be extra-articular, they can be intra-articular. They can involve comminution. And of course, the worse an injury gets, the more likely the patient's going to be one of the patients with complications such as stiffness. But given that most people do fairly well, fairly rapidly, remember that when you're looking at studies, that it's the complications that have the greatest potential for us as therapists to get people better. If we're trying to get someone better who's already going to get better, measuring that is a bit difficult to compare. Stiffness. It's really about limited range or loss of range of motion. And there has to be an element that's actually affecting daily living. And so it's potentially still a little bit more than what we would previously consider functional. But it's a level of movement that's making it difficult to function or causing potentially discomfort or pain. And so how we might measure that or check that is going to be about where someone's end of range is. Can they flex to 40 degrees? Can they flex to 80 degrees? Or any other position? At the below, we've got around 80, 90 degrees of supination in the cartoon, and then around a similar amount, or just a bit less, pronation. And this is really important because end of range is what determines your stiffness measurement or endpoint, but it's also how you need to figure out how to treat someone. If you're stretching, if they've got 40 degrees of movement and you move them to 30, that's not a stretch. If you put a brace on to 30, that's not a stretch. That is not end of range for that person. So for me, my end of range might be 80, 85 degrees in supination at the moment. If I had an injury, it would be less. So of course, I need to stretch in a different position should I be aiming to gain end of range or improve stiffness. How do we assess it? Well, this is probably my most common referral, and it's not really stiffness. Hey, Jeff, can you see this patient? I've just taken a massive dressing or plaster off. They can't move. Can't they move, or haven't they moved? So I guess there's an element of stiffness, but it's a fairly resolvable one. Real stiffness that's still presenting down the track, and that's stiffness that's recalcitrant to treatment. You want to do a better test. And what you're testing for is really, does it adapt to a bit of education and movement? One of the ways we do this is to actually, in the weeks test context, is to measure the movement. You can see it in the bottom left, measured in extension. And then you heat and stretch, and you may use other modalities. This is a highly modified version of the weeks test, which wasn't even designed for wrists. And then you remeasure. Now, if someone responds really well to stretch, then not that stiff. That's great. That's easy, we can move on. But for those that don't move very far, then they've got stiffness. And I guess the less you move, the more stiff you are. And theoretically, the less likely to stretch you are. But that's pretty loose. Another way to assess it might be using a PROM. This one's the patient wrist and hand evaluation. A fantastic cue for asking someone about their function. So things like, can you use the toilet tissue or dunny roll, as we may call it here? Are they supinating? Are they flexing? What position do they go in for that? That's going to be a long conversation for tomorrow. Can they turn a doorknob? As in, can they rotate or either supinate or pronate, depending on the type of knob they have? Can they push up from a chair? Are they extending to do that? If you identify some of these things as unable to do or significant difficulty, then it may be for reasons such as stiffness. That's the likelihood. So, what causes that 20 to 30% of people, we say a distal radius fracture, or even more with some of the elbow injuries, to have stiffness? Well, it can be any of the tissues or a combination of all. It can be from the bones in the form of malunion. It can be from the ligaments and the other soft tissues. And any and all will and do cause stiffness in all directions. And we'll go through some of the key players in that. I'd like to start from deep, starting from the bones. The big misconception is that a little bit of malunion is the reason for stiffness. And actually, that's not the case. To understand this better, we need a good radiological understanding of where the bones for our patient are sitting. We've got to remember that radiology is a 2D, or X-ray in this case, is a two-dimensional image of a three-dimensional object. And it's your job to actually translate that back. So you can see my markings there of on the left in image A, and you can see that you've got the volar lip here approximately, and then the dorsal lip of the distal radius there. And of course, you've got the very important sigmoid notch. Now, from that, you need to follow all the lines of the cortices around. You check. You don't just check here, you go around. And then you go around, you do the dorsal lip and the volar lip, because we know it's a three-dimensional structure, and we follow it around. And we systematically do that for all bones. Now, I'm not going to go into too much more detail. I'd love to do a radiology tube sometime. But we need to do that in, of course, at least two different planes. So we look at the lateral after we look at the PA, and we see where say that the druge is located. Is the ulna dorsal? Is it sitting volar? How is it approximated relative to the radius? Or rather, how is the radius approximated to the ulna? And of course, we look at an oblique. That gets a little bit more complex. In both views, we want to look at the carpus as well, and we go through that systematically. We know that imaging has a really poor correlation between radiology or radiography and range, as well as some strength and patient-rated outcomes. But it can give us a little bit of an idea as to what might be going on, or more importantly, what might not be going on and what we shouldn't worry about. So I use the rule of 11s, and that's pretty straightforward, but essentially you're looking for radial inclination of 22 degrees, or it's actually, I think, 23 normally, and the 1 + 1, which would have made 11 once upon a time, being the 2 millimeters of normal ulnar variance, which tells you about the radial height. Has the radius fractured and lost height? And then, of course, we want to know the palmar tilt, which is usually around that 11-degree mark. That's a really easy way of remembering some of the parameters that we need to think about on a basic image. And of course, we need to look even more detailed at Gallioli's lines. We need to look at the carpal heights. Do we need to see, is the scaphoid flexed? Is the lunate extended? Is there a humpback deformity in the lateral? Again, things for another day, but things that can cause stiffness. The ulnar styloid fracture is commonly associated with the distal radius fracture, and it's something I see therapists all the time freak out about. It's not associated with ROM in most cases or other outcomes. And non-union is actually remarkably common. So we see an X-ray here from Radiopedia, and you say that's non-united. I think that's fairly well corticated. So that's down the track. And we know that because it hasn't moved too far, that the ligaments attached to it are probably still intact. So don't see that and say the patient's in non-union, I'm scared to move them. Articular step-off may affect stiffness, but of course the big thing about that is going to be secondary arthritis if there's more than a 2 millimeter step. Now, that may be an indication for ORIF, but it is worth remembering that sometimes despite ORIF, a lot of patients still have a post-op step-off. This is really hard to assess in radiology and beyond today's scope of discussion. So these are some cadaver studies, and they're really nice because actually you can see what just the bony change without any further fibrosis or change to the soft tissues does in the presence of dorsal tilt, radial shortening, or the rest. But we can see that it takes a huge amount of dorsal tilt to change the rotation, or to actually decrease rotation significantly, well beyond the parameters of what tends to be left in our population. Radial shortening can actually be fairly well tolerated from a rotation perspective as well. There's a level, which we'll discuss later, but before you start losing something like half of your movement, you need 10 millimeters of radial shortening without having further fibrosis contributing to it. Now, 10 millimeters of radial shortening, I can tell you, is a huge amount and is very rare in clinical practice, and certainly very rare to be left like that without ORIF and re-lengthening. So for flexion extension, really they tend to follow the tilt of the radius more than anything. So if the radius dorsally tilts and the angle dorsally tilts, then you tend to get maybe a little more extension, but you actually lose some flexion. And conversely, if you get more of a volar tilt, more than the normal, then you'll lose some of the ability to extend off that pivot. So volar tilt and then less ability to move dorsally. Dorsal tilt, less ability to move volarly. Shortening on variants do have a role in loss of motion, but only it's the far extremes. So malunion is a contributor, but not in the Australian context. It needs to be a significant amount to be causing it. Now, so what is acceptable in a typical context? Well, for adults under the age of 65, these are the parameters. And you'll see that they are above the tolerances for what we talked about for causing stiffness. The likelihood of you seeing stiffness in that with that without it being ORIFed are fairly low. The parameters for the older population are a little bit more loose, given that their function may be a little less and their demands may be less. That's not for all cases, but it's certainly for a lot of cases. And so they'll allow for a little bit more radial shortening and a little bit more tilt. So stiffness, it can be capsular, extracapsular, bit of both. The causes vary, but the vast majority of it is the soft tissues around an injury, even if there's presence of malunion. The patient factors make a difference. So swelling, probably more in the acute and inflammatory phases. The chronicity, if something's left a long time, then that can be a cause. And some of the other variables, smoking, that can cause stiffness. And of course, there are genetic components. Now, you're not going to test someone's human leukocyte antigens, that's the genetic component, but you can check their other joints to see how stiff they are. If they've got a propensity to stiffness, they might have also had a history of stiffness after injury. So think about some of those things. But you want to consider these things when you're screening patients. So a big part of healing when we have a fracture or an injury is going through inflammatory, proliferative, and then remodeling stages. And that is similar, whether it be a bony or the soft tissue or a combination of both. Now, that's a normal response as long as it follows the normal time frame and doesn't over proliferate. You're not laying down too much bone, or probably more so, laying down far too much fibrocartilage and fibrous tissue around the joints. And so there are many things that can affect that. So soft tissue contracture is one of the big things that causes stiffness. It is the most common thing. It's a pathological response typically, and there's cytokines and which obviously change what cells come along, and of course whether you end up with changes to the collagens and the fibronectins and cross-linking and fibroblastic proliferation. But we've all seen those sort of risks that they're at far thicker and far more fibrous than they are bony. And that comes down to things like some of the risk factors. Some of the things to screen for are really high energy fractures, intra-articular fractures, prolonged immobilization, and delayed rehab, as well as some of the genetics, which we can't change. We can just screen for. If you have a broken bone, you also have an injury to the soft tissues. If there's one wound, there's one scar, and it's the whole lot. If you have a broken bone, you have a zone of injury that goes around the fracture. It includes the ligaments and the tendons and the muscles, and it certainly includes the capsules and the joints. And this is what ends up happening. The wrist can spot well with like an arthrofibrosis, internal, intracapsular, extracapsular. The good news for us as therapists is that soft tissues can stretch if they're given enough time to adapt. And this is where we come in. So, malunion does not equal stiffness. A little bit, usually quite well tolerated, and will not explain the stiffness that we see in that 20% of people. Our job is to identify potential complications. You want to screen for the things that could cause them, and you want to initiate early treatment for anything that you can identify and work around. So don't let radiological non-union cause you to immobilize for too long. There's usually good fibrous tissue long before there's bony tissue, and it doesn't deform after a couple of weeks in typical cases. So don't sweat a little malunion, but also get the fingers moving, get the thumbs moving, get them doing light function before you worry about the wrist union, because it's one more thing you don't have to worry about later. Worrying about more than one thing at once, hard work. So, routine distal radius fracture is pretty straightforward. This is without stiffness, and this is where most of the studies lie. It's certainly where most of the good evidence lies. Most patients, they have a good start point. If you look at half of these studies that say therapy does not much, patients started with really good movement. And when the study came, there wasn't much to improve. So they were going to improve with a bit of education and the home exercise program and a few other little bits and pieces. And so the evidence, if you're wanting someone to tell you there's an RCT that supports therapy for all distal radius fractures, sorry. And you'll come up against this time and again. Surgeons love RCTs. Our RCTs are done on patients that are going to come good. You need to start looking at the evidence of the people with the complications. They have something to gain. They start off poorly and show big improvements. And again, most of that's anecdotal evidence and case series and cohorts. We haven't got the RCTs behind us for some of it. So, typical distal radius treatment might involve a bit of active range, passive range, might involve some stretches and strengthening. Maybe taking on some function. But if you start off good, you'll end up good. Most people will be fine with that. And how that's done in a practice might be around patients' anxiety or education and trying to manage so that they feel good about the way they're progressing. in that context, for most people, if you compare that more treatment to a home exercise program, the outcomes will be fairly similar. So home exercise program and education is the mainstay for your uncomplicated distal radius fractures. There's limited evidence for doing a lot more. There's very limited evidence for doing even the active and the passive and the stretching and strengthening, because if you look at most patients at 3 months, or 6 months, or 12 months, they'll end up pretty good. So don't fix what ain't broke or what ain't gonna be broke next week. You know, maybe pick a limited amount of things. You don't need to do active range, passive range, strengthening, return to function for all patients. It's unnecessary and it's tedious. Figure the patients that need it and give them what they need, not more. This is just a little table you can see, just comparing the average distal radius fracture with either like one-on-one treatments or home exercise program. People found either it's a little bit better to have a home exercise program at the bottom, and then, or it's a little bit better to have a supervised program at the top, or not much difference. So where does passive range come in? We give it to most patients, surely, especially if there's a little bit of stiffness. Well, actually, the passive range you'll see is really limited at gaining more. Sometimes it's kind of like giving me a passive range exercise program. If I stretch into a bit more extension, I'll probably get 3 degrees of extension more, but I've got full movement to start with, or pretty good movement to start with. So this is what they find. The mainstay of our treatment for range is that, and it's one of the RCTs that we keep going back to, is done by Kay a long time in 2000, and they started with accessory modes, PAAP, and then they moved towards physiological PROM, and they found those fairly modest differences here. It's not a lot, but it's because most of their patients didn't need to gain too much. So other treatments that there are, this is a really recent paper, it's still in press from last year, done in Melbourne, and they did individual and then worked towards group treatment, and found had using the Haggett's approach, a proprioceptive type approach, that they had a few gains, and so potentially not as strong in the range, but that because those movements were fairly limited and many weren't statistically significant, although the supination extension gained 2 and then 5 to 9 degrees, and then that's potentially an extra 15 degrees of range through a program like that. And so that'd be well worth having to think about. And potentially you'd gain even more if you're looking at a stiff population. So this RCT also found actually very similar between control and activity-focused physio. This is a case study, and I thought I'd bring it to people's attention. It's fairly weak evidence, but really significant improvements in range marked down the bottom for someone who had an ORF, post-distal radius fracture, CRPS, and they were well down the track. But because they had such a poor start points, flexion, extension of 10 and 15 degrees and minimal movement, they actually had fairly significant increases in their movement. So from a case study perspective, there are lots of ways to improve people that have stiffness. Other things to consider that really we probably don't use on a regular basis are probably more for the people who are trying to get that last percentage early. And this is why your distal radius fractures, looking at flexion and extension at the bottom and rotation at the top, if you track them, the movements start off pretty good at 8 weeks. You know, that might be sort of when you're really getting into some of your therapy. And this is without too much treatment. You can see they end up with really good movement anyway. So again, as a comparator, the ordinary cases aren't too great, but they end up great. They end up really good with or without treatment. But it still leaves about 12% of conservatively managed distal radius fractures that have stiffness. They don't alter the data much, but they have stiffness. And then of the ORIFs, a slightly higher rate. Not because of the ORIF, just because they probably had a worse injury to start with that inspired the ORIF. But there's a few patients there that I would suggest we really have a big role in changing their outcome for the longer term. This one used combinations, again in a case study, for someone who really presented late and did all those treatments we talked about. And you can see really significant gains from no supination to 90 degrees at 9 months. And similar gains from no extension to 45 degrees and so forth. And that's using a pegboard, which works with a bit of elastic and like passive stretch, which we'll talk about later. The take homes are this: simple treatment for simple fractures. Target your treatment for what a patient needs. If they're doing all right, they probably don't need too much. They just need a bit of encouragement and education, and maybe a home exercise program. Once you've got complications, these are the people we're really interested in, that we can make a big difference for. So most patients will do really well with home exercise program. It's the stiff patients we're thinking about. Now, if you treat wrists, then you treat stiffness. There's limited RCTs. I'm sorry, the evidence is really poor at that level. And so that can be a referral barrier to getting patients into your door. Now, lots of patients will gain some extra range with all these passive edema management, weight bearing, sensory motor strengthening, all the rest. And then you need to start thinking about end range time splinting. So for patients with a little bit of stiffness or a moderate amount of stiffness, first of all, I'd troubleshoot. What have you been doing? Patients always say, oh, I'm stretching all the time. When you say, oh, what's all the time? Oh, every day, once a day, you know, strong stretching. And you go, well, how are you stretching? And then like this, and you go, can you go like that? Yeah. Yeah, well, you know, until you actually check them, ask and see what they are doing, it's pretty hard to know whether they have really just a bit of simple stiffness that they haven't been able to address. And the other thing I like to test is I like to give someone something with a bit of weight if the fracture allows. I want to see whether they're scared to lift it or whether they've been cracking on. It tells me a lot. So focus your treatment. Focus, I think, the passives, the weight bearing for extension and the return to function, and then look at splinting. I'm going to give you some little handy tips here. So the first thing to do when you're looking at extension is think, well, the wrist is a weight bearing joint. Now you might not do this at week 6, or you might think about it heading towards it soon after that, depending on what you thought the union was like. Later on, you're going to ask, how do you go getting off the floor? Because that's when you really need to push wrist in extension, pushed passively by the floor. Or how do you go pushing it off? You can assess it by a push-off test. And you can look at the extension range. which again, I'd look at in active and passive for extension. The prayer stretch is a really common one. I'd increase the duration. You know, like people sit there and do this for a minute and then they're done. Increase the angle. You can start here, and the lower you go, the more the angle. Get it to their end of range. Otherwise, it's not a stretch. And if you want to work towards weight bearing, you can push against the other hand incrementally. A little push. Oh, yeah, that feels all right. Bit more. Oh, yeah. Until you can really push, or till you need to move towards a push-up. You can do push-ups on a wall. You can work towards the floor. And I think people routinely get up and down off the floor or off things like that. Many of us do that all the time. So that means we need to be able to take a little bit of weight at the end of our rehab. And that'd be my discharge day exercise. I would make sure someone can really lean on the wrist as they feel they should, if it's feasible, unless we're discharging them weeks earlier thinking they'll get there anyway, with some advice. Now, on the wall, you can start from the left, bottom left, to the right. You can start with the arm a little higher, if you think of that as flat, and that's the wall. You can see I've got a shallow angle. As I move my wrist down, sharper angle. That's good for improving extension. If I want to take some weight from that, make it harder, I step a little bit further away from the wall, and then I'm taking some weight as well as extension. And then, of course, I want to move to my knees, to my toes, for many people. And not everyone will need to get to that level. But I think it's useful, especially for those patients that do lean on it. And I wouldn't write off your geriatric patients. They often use their arms to get out of a chair or a couch or a sofa. They need weight bearing too. It might not necessarily need to be a one-armed push-up. So, simple stretches. Making some stretching good and achievable is really important. So this is one way I do it on a couch. You can sit there for minutes and minutes and minutes. You can increase your dose, and then of course you can increase the amount of stretch. One of the pitfalls, I see people put dumbbells in people's hands. In the first instance, the dumbbell up there is for a supination stretch. Now, the center of gravity on a dumbbell is not set up for that, but also you've got to grasp, and the minute you do that, you tense up a little bit and it creates a tenodesis. Similarly, for the flexion stretch, if you put a dumbbell in your hand, and try this later, it doesn't pull you all the way down like the leaning on the couch one does or anything else. And also, the minute you use your flexors to hold the dumbbell, it pulls you back up into tenodesis. So, rotation, one of the pitfalls is stretching at the hand, because we're not trying to get carpal rotation. We rotate from the proximal and distal radial ulnar joints. We grab at the druge. So the other thing to think about, and this picture on the bottom right, I think they're probably a bit distal with their stretching hand, but I think what they're doing really well is thinking about working towards overstretching. If you stretch someone to 80 degrees of supination in a case, they'll be comfortable at 70. If you stretch them to 90, they'll get to 80. You'll always lose a bit of stretch after you let go. So you've got to overshoot your aim. Using a dumbbell for, a tin of beans for rotation is, well, have a think about where the center of gravity lies. The center of gravity is there. There is no torque force like there would be with, say, a hammer, where the center of gravity is further at the end, or when we rotate around to supination is far end. So think about using a stick or a hammer or a broomstick or something like that. And the other thing I'd think about is if someone's stiff, don't give them like one set every couple of hours of exercise or heaps of resistive training, because it's taking time from their stretching. Try and also implement the stretching into when they're sitting on the couch or sitting at their desk. Can they sit there like that for flexion and use the weight of their slightly oversized noggin to lean onto their flexed wrist? So when that's not enough, you need to think about persistent stiffness. And I like to raise this early. This is where you do that modified weeks test or something. Really check. If it's going to persist, then you want to be on top of it sooner rather than later. There are a lot of barriers. Some of them come from the patient. Some of them come from us. Oh, that's going to be uncomfortable. And I'd say, well, compared to what? Compared to no movement or bad movement that you're complaining about anyway. You're uncomfortable for the hours that you're in it for a month or two, not for the years that you're going to have that limited movement. The limited function is similar. It's a brief time. They're often not sure about the efficacy, and I think that comes from us. We've got to understand the studies that have proven or tested things so that we're confident that we can make a difference with something like a splint. Some of them are just happy with what they've got. Some of them have that ignorant, oh, it can barely move now after 3 or 4 months, but the doctor said it'll get better with time. So I'm just giving it more time. It won't. For us, it's hard end feel. It doesn't feel like it moves anymore. We're thinking there must be malunion or something like that, or there's a little bit of malunion on the x-rays. Oh, or it's been months and months, or we haven't got them any further with all this good therapy. And you think, well, I've been stretching them for half an hour twice a week. It's not a lot in the scheme of 24 hours of the day, 7 days of the week. And they might even do a home exercise program here and there. Sometimes it's us making the splints. They're hard, they're technically demanding. I can't always make a great one, depending on what design I use. And then there's the cost, and you think, oh, look, they've got functional range, even though they're not happy. I really don't know whether I want to do this right now. And then maybe you're just not sure that it'll work. But I can tell you, for the stiff patient, how long you hold the stretch matters. Now, I doze off after a few minutes of this. I've forgotten what I'm doing. I'm like this. A splint will hold me after I forget. And this is where end range time splinting really comes into its own, really for stiff patients. So this is what you'll come across. Now, I know there are hand therapists here. There are orthopedic physiotherapists, there are generalist OTs, there are chiros. We come from all different walks of life. So you'll see some really confusing terms that probably mean similar but different things. You'll see dynamic, mobilization, orthosis, all the rest. I'll probably refer to it as end range time splinting because there are different ways of addressing this. So why does this work? Well, it changes the dose. A really diligent patient might do 5 minutes here, 5 minutes there, 30 minutes of the day. The patient with a splint, they'll stretch for 4 hours or more per day, depending on what they need. So we use the umbrella term mobilization orthosis or splint. And there are a couple of subtypes. But really what they do is they put the patient into end of range if they're doing their job, and therefore the patient gets an end range time where they spent time at end of range. The dynamic splints use theoretic creep loading. So they use a spring of some sort or an elastic, and that creates a stretch. It stretches the joint for hours, over weeks, months, and the tissues gradually lengthen. Stress relaxation, more of a static progressive. You stretch a bit, you wait for it to give a little bit, you stretch a bit further, you stretch a bit more. Essentially, not fully sure why this works, but the thought is that it slowly increases the soft tissue length. Some of it by breaking malformed disulfide bonds, which cross-link the collagen and cause a lot of the stiffness that we talked about earlier. But they don't do tissue damage. So really, what's the most important thing of this? Well, probably the most important thing is that you spend hours at the end of range. It causes a viscoelastic deformation, which, remembering that the viscoelastic properties or the stiffness properties of the soft tissues are the big causes of stiffness. The idea is that you spend time in these zones 1 and 2, where the length of the tissue slowly increases. You don't crank until failure and then breakage, and you don't push so hard and stretch so forcefully that you create inflammation and more fibrosis. Because remember, if you offend the tissue, it's going to spend the next 24 to 48 hours inflaming and adding more tissue. So what you want, tissue lengthening with low load, prolonged stretch, hours of moderate level stretch within those stages. The lengths will change over a period of time, both acutely and longer term. You'll put someone in a stretch for 5 minutes, you'll see their end range is a little bit further. You do that for weeks, for hours on end. It goes a little bit further and a little bit further and a little bit further. And then the next week, their start point's a little bit further again. So why does it work? It's just hours per day. We don't know a lot about what does and doesn't work. There's a lot of questions in the literature. If it's been too chronic, can you affect change? Well, it'll be a little harder, but yes, you can. If they're really stiff, they didn't move in a half-hour session. No, actually, you can still improve them. So if they've got a real hard end feel, you can still improve them. If the therapy's been failing and plateaued for a couple of weeks, you can still improve them. Ideally, we like to start earlier. But really, the main thing we know is the time is the key, and the longer you wear it, the better the efficacy. There used to be splint choices for different phases, and to some extent these still hold, but a lot of it will come down to not so much how stiff a patient is or how chronic it is or anything like that. It might be about what you've got available and what you can make or get hold of that can work for your patient. So how do you get it within these splints? Well, you tell people that they're getting hours of stretch a day. A week or two later, they inevitably see those results. They'll be happy with that and they'll keep going. You've got to test the splinters holding at end of range. If you can use a design that enables function, but that's not always possible. And I'd consider using it in sleep. Ooh, controversial. Is it contraindicated to put something on while they sleep? No, it's contraindicated in certain circumstances, or if you're cutting off the circulation, or if you've got someone that's not neurovascularly intact. So check their skin, check for a few different contraindications. You know, if they're taking sedatives or they drink a lot, trial it during nanonaps. If they're not getting any paresthesia or any numbness for a few hours of wear, then they're probably not going to get it any more than I get a numb shoulder when I roll onto my shoulder for too many hours. It's one way of getting stretching while you sleep, but I think needs to be used with a little bit of caution. We want to know, do these things work? Often they do, sometimes they don't. Lots of good case series on this. So we're going to start with rotation. You can see the top splint is stretching into supination. And this is on, these are all these case series, by the way, are on patients that plateaued with therapy, plateaued with home exercise, plateaued with passive ranging, passive mobs, all the rest of it. And they're usually a bit of a way down the track, longer than preferable. But the top one, you know, gained 34 degrees of supination over a period of about 10 weeks. They're getting 4 to 8 hours of stretch a day. So, of course, given that they started off stiff, that's not true. They gained more than that. They started with 34 degrees of supination on average and went up by about 50 degrees to 82. So if you start poor, you've got a long way to go and you've got a lot more potential. So in the stiff cohort, these things work. Similarly with the splint below by Shah, they used it on Colles fractures, Smith fractures, intra and extra articular. that splint goes in pronation and supination. Again, they spend hours of stretch, and they did 13 hours. I think they gained, I'm sorry, I've done a typo there, but I think they gained about 40 degrees from memory. Parent Weiss did a similar thing and gained 36 degrees of supination, 26 degrees of pronation. Now, that's about 60 degrees of rotation on people that were getting nowhere. They used the top left splint, which is a serial static progressive. A couple of people have tested the JAS splint below. This is one of our competitors in a fantastic splint. It holds at a really good end of range, gives a firm stretch. And of course, these patients gained around 40 odd degrees of movement, despite all those unions, therapy plateaus, chronicities that we put as barriers. It also improved their function generally. So when you get more movement for a stiff patient, their function and happiness generally improves. What does gaining 40 to 50 degrees look like? Well, it looks like going from, I'm quite limited. I'm nearly at the functional range, but I'm struggling with all those things we talked about earlier, and it's a bit stiff, to, I can start carrying things, or I can hold a phone, or I can wash my face. This is probably about similar sort of thing, maybe 50 degrees, pronation, again, stiff, not great movement. Gaining 50 degrees or 40 to 50 degrees will get them all the way of a loose movement. It's a lot. It's a real lot. In extension splints, the literature is varied. One of the best studies was obviously an RCT by Jongs a few years ago now. And they really had minimal gain. They used the splint here, which in my hands also hasn't gained much in the way of stiffness. I find it quite difficult to make and get a good surface area and a good pull through the outriggers there. But they tried for 12 weeks and found very similar gains to normal treatment. So that was a little disappointing for their patients. For those that tried the Dynasplint version, they had a sequential amount of forces to go up with, and they went from half a foot-pound, which is an empiric measure of torque, essentially, moving up to nearly a whole foot-pound. But basically, they went from a fairly minimal stretch to just wearing these at night with a fairly significant stretch. And they gained, they gained about 16 degrees, but in context, that was a bit over double, or a bit over half of what the patients already had in extension alone. So that actually may move them towards a functional but awkward amount. Again, in extension, nearly 20 degrees there, but a really good improvement, again, in the case series of distal radius fractures. So I think for patients that are otherwise plateaued, they're gaining some extension, but not as well as they do in rotation. Flexion splinting has also been done, and mostly that's been tested with a JAS flexion splint. And so they found fairly significant improvements in the total arc of flexion and extension of 34 degrees, which in the context of people starting with 67 degrees is gain of about 50% of their movement. So fairly reasonable. And again, Ricardo had another crack at a similar study, just working on flexion, and their patients went from 30 to 41 degrees, which is about a 36% gain. So different movements have different efficacies with different styles of splints. But to give you an idea what, say, a 50% gain might look like from stiff to not stiff, you know, in extension at the top there, you can see it's probably enough to get you closer to where you want your hand in space, and then in flexion, and it might get you closer towards, again, not as such an important thing for function, but might be really nice for, say, using the toilet tissue. So these splints are better and work when therapy plateaus, and they work on the hardest patients after months of treatment. In rotation, they have really impressive gains, and even in flexion and extension, they have some reasonable gains. There are some things you have to check, like the person's perceived amount of stretch. You know, you might want to work up to actually, you don't want to be in painful stretch, but you also don't want to be in no stretch at all. And I think we've all made splints where people have gone, oh, that's not stretching. And you think, no, that's really not stretching, but that's the best I can do. And so you should test your splints. And to test, basically, you put the splint on and then you push. And so with this one from the RCT earlier, if you push and the hand goes back an extra 10 or 20 degrees, it's probably not holding them at end of range. And that might be a good explanation for why they're not making gains. With the splint on the bottom right stretching into supination, you push around into further supination, you see, does that work? We commonly see these, and this is why you check. You should always check. You send neoprene. The person's let go by the therapist, and this is supposed to be holding them in supination, but you can see once they rest, they're just in mid-prone. And of course, the taping sort of does the same. So we don't really expect a lot of results from that. And I think that's probably why no one's really bothered testing neoprene or taping in a research context. And I haven't considered it in years. It's an easy out, but it just doesn't work in my experience. This is something that is fairly easy enough to make out of thermoplastic, and I've had really variable results for myself with this, and this is a 2-part wrist and elbow splint. And you can see that when I tested it on a fairly loose wrist, this is mine, and I've made this the best I can out of some fairly stiff materials, because if you make it out of thinner materials, I've never seen it hold in range. And I've seen it made by better splinters than me and better hand therapists than me. And so this one, which I think was made pretty well and worked, I'm not convinced. It's certainly not holding it out of range, so it's hard to know whether it's going to work to get me more supination. So you've got to make some choices, and there's so many to choose from. Some that really aren't choices, and some that are. Some that aren't too available either. But really what it comes down to for me is it going to hold at the end of range? And therefore, is it going to work on a stiff patient? And so for rotation, these are some of the ones I think about. I'm not quite convinced on the wrist and elbow component one. A Colello works really well, which is on the bottom right, but you can see it's a big and bulky splint, and of course patients hate wearing them. So, and you know, it takes me a good hour and a bit to make one, and most of us struggle making them, to be honest, and then struggle convincing the patient to wear it. So things I avoid, I guess, I avoid this one because I'm not convinced, and I've had really variable results. It may be because of the splint type, and it may be because of patient, maybe for a lot of reasons. This one I avoid just because it's big and ugly and cumbersome. But I used to make a lot of it, and it was great. I avoid this one because unless you've actually got a reasonable amount of flexion, the leverage point is actually very close to the point of the moment arm. And that's the same in extension. So it's very good for these possibly hand therapists modeling their own splint, have good movement. They can pull a little harder because it's out at 70 odd degrees. It's out at 70 degrees. But I put it to you, if the wrist is sitting here, you're pulling almost directly with an axial or compressive load as opposed to a flexing load or an extensing load. Oh, sorry, I haven't made those ulnar deviation ones, radial deviation ones in a while. And it's mostly because once you work on the flexion extension, people are pretty happy, and those deviations improve a bit as well. But you've got to work on the rotation and then extension, and they're always your priorities. And usually you've burnt a patient out long before you start getting to deviation or some of those other things. And so these are my choices for rotation, and I think they're fairly reasonable choices. And I know the capsular release or surgical release is something we use as last minute. It actually has fairly good efficacy. And for my patients, I try one of these splints first and tend to have such success that we're seeing a lot less patients that I need to send for capsular release. But for those that don't want to wear one of those splints, it's either put up with what you've got or have a capsular release or wear a splint. For extension, I use the one on the left, and I think that was made by a colleague of mine, and I'm pretending to smile, of course, or I've eaten a lemon. But you can see I use this design because the pull is actually a lot higher. And while I've got fairly relaxed fingers, and I'd probably relax them a bit more if I was making it, I just want a really nice pull on that, so it goes up a little bit past the distal palmar crease, but pulls through the almost the metacarpal head area for the most leverage. And then I've got a really good bit of neoprene there holding it in tight so I don't fall out of it or lose some of the stretch, because if I'm not in the shape of the splint, I'm not in the actual stretch anyway. And some of these other ones are otherwise good options in extension. When it all goes to whatever, or you can't get hold of one of those splints, or you don't make a splint, or you can't convince a patient to wear them, then this is probably the other option. And arthroscopy is really the common thing. And you can see they release along underneath and around after pairing off around the extrinsic ligaments. These are typical results for that as a treatment. You can see a fairly impressive flexion and extension, again, in case studies. And what's really nice about that is actually the evidence for that as a surgery, you can tell them, is also considered low by the AAOS, or the American Orthopedic Association. So they're fighting the same battle we are. They have a way to treat it. We have a way to treat it. Both have fairly good treatment outcomes. They just don't look good in the research. So splints are the mainstay for real stiffness, and they work even when everything else is failing. And they work despite all these variables that we've talked about a fair bit before. The key really is getting a good end of range and a reliable splint to hold it there, and then longer wear time, and just letting a patient know that they need to wear it for a few hours a day, and that's how they get their real stretches in. If you treat wrists, you treat wrist stiffness. And I go through a mum checklist for all my patients that I'm not going so well with. In this context, did they get to an end of range? Is their end of range supple? Is it comfortable? Have I done everything that I can do? And then when it comes to, if the answer is no, it's put a splint on, and that'll fix that probably better than anything else I can do. And I have to go through, does it hold at end of range? Is cost a consideration? It can be. I'd put it to you that, you know, you're paying a one-off cost for a splint, and you're getting a result for the next 10, 20, 30, 50 years, depending on how long you've got to live. Or you're going to put up with stiffness for a very long time, typically. And I think a patient should be told, you know, this is a really good option. Whether I can get it to you or not, maybe my colleague can, or I can refer you to someone that can, or I can buy one off the shelf that might be pretty good too. There's often some pretty good options around. So thank you very much for your time and for listening to us. We've been very excited to present this. We would like to offer up some questions, and I think Brodwen is now going to open up for some of the Q&A that may have been brought up before.
Yeah, so we have a couple of questions that have come through. So one of them is, there is a bit of evidence to suggest heavy eccentric loading is more effective than static sustained stretches for shoulders and lower limb conditions. Do you know if this has been researched at all in wrist stiffness?
First, I don't know, but I think not. So certainly last time I did a lit search, I wasn't aware of it. For a lot of that stuff, I think it's a really good point. I think, these splints work very well for adhesive capsulitis, believe it or not. Not a wrist splint, but a shoulder aeroplane. And, conversely, what works as far as eccentric loading or any of those sort of stretching mechanisms will probably work and be translated to wrists. But I don't think the study's been done, and I think you should do it. It may be a little harder sometimes considering the leverage you have for eccentric loading. In that, if you think about holding something from your wrist, the center of gravity is 5 centimeters from the actual pivot or the main pivot of the wrist in the flexion extension arc. But it's possible that it might do something. And I think it's well worth looking into.
Great. So Angelina Lee has asked, what do these splints typically cost?
Yeah, I was trying to keep away from the sales pitch. Our one for rotation is on sale at the moment for $199, and that's a really good one. The Jazz splint, one of our competitors, is a really good one. You saw a few photos of as well, and that goes for about $600 or $700, depending on how strong the US dollar is at the moment. And if you make them out of plastic, well, then they probably, if it's a Colello for rotation as a comparator, then you're probably looking at a good hour and a half of some of the more experienced hand specialist therapists usually to make, because it's a complex splint to make. And I think in Melbourne, there aren't many of us that do make a lot of them. So you're looking at a good hour, maybe an hour and a half, plus, a good, I would have thought $50 worth of plastics. For the ones that don't work, like tape, well, I guess if you use enough tape until you run out of patience or get a result, it'll cost you millions, because you won't get a result. But actually, that's fairly cheap. And neoprene also, I think they're about $70, but I wouldn't bother. It's a waste of time. I think that's similar across the board for extension and flexion splints. And I'd leave you to go through our slides and Google what you think might be good, but evaluate, do you think you can get someone to end of range with it? Do you think you have the ability to get them at that? Or maybe find a trusted hand therapist that isn't trying to steal your business, that might be happy to make something for you, but not necessarily take over your patient if you're wanting to keep going, keep seeing them. But some of the prefab options are really good, and we're certainly expecting as good a result, if not better, to anything that I can make from the prefab rotation orthosis.
With such a sustained long period of stretching, do these patients then find it painful to go back in the opposite direction?
For the first hour or so, sometimes. And I'd pre-warn them that. I think with anything, once you gain some movement in extension, you lose some very transiently in flexion, or it's just a bit sore. And I often break up any passive stretches or splinting into, just work on one or two things at a time. I think going straight from an extension stretch, for example, straight to a flexion splint causes pain. Why would you do that? Why not do extension and then maybe do supination and then go on to flexion after that? You've had a bit of a break in between. So yes, you should expect some discomfort while stretching and whilst in the splint. If you're not getting that discomfort, I think the patient knows as well as you do, it's probably not holding at end of range. And once you release, you'll also get a rebound tenderness of sorts. And that's okay, it goes.
Yeah, and just to add to that, I think that there's an element of warning your patient about that as well, so that when they take the splint off, don't get a shock or a surprise that they're a bit stiff and sore in the opposite direction, and giving them that reassurance. So Jenny Greats has asked, how does smoking increase stiffness?
I think it's to do with metalloproteinases and macrophages, and it's quite a complex mechanism. It's better studied on the stiffness of the lung in COPD, but it's a systemic thing, and it's a complete pathophysiology lecture. You may notice in the bottom right-hand corner that that is one of my undergraduates, and I've done some extra studies in those areas. But I think that's tomorrow's topic. It's really, really tedious. Just know that it tends to.
Susan Roy asks, how would you treat wrist stiffness in a total wrist replacement?
So I think you've got to figure out what you're aiming for in a patient. You're not aiming for necessarily the same amount. And whenever you're doing, say, a joint replacement, you're aiming for whatever the prosthesis can allow. And then you should look up what that or anything else allows as a typical thing. And then the tissues around it will obviously cause a secondary stiffness, and some people will be suboptimal to that. But I'd start with goal setting and understanding that that's about the intrinsic part of a prosthesis, and then the capsular part, which may be patient factors, but making sure that you do that. And I think from that same approach, as long as it's got a stability or the cement allows or whatever else, and you check with the surgeon, I think it's quite reasonable to use the exact same mechanisms you would, but because you're trying to affect soft tissue change and adaptation. So the principles are the same. The goals are different.
Yeah. And in consideration of zone of injury, where does the literature stand on active exercise for tendon glide following periods of long passive stretch when trying to improve active range of motion?
Yeah, I think that's a great question. I mean, I'm not a great advocate of tendon glides. I think they're often the indication for tendon glides is not having tendons existing. So if tendons are moving, and if someone can make a fist and extend, then their tendons are probably moving habitually in normal life. What they do to the wrist, is a little unknown, but I think one of the other problems is if you've got someone doing this, for 1 or 2 minutes when they could be stretching otherwise, I think they need to limit their goals. We've got too many patients doing tendon glides, active movement, passive movement, strength training, all this. And when you think about their home exercise program, they're spending hours, but only a few minutes on the things that matter. So I don't know, but I'd probably be more likely to focus on the things that I think are likely to work.
There's a follow-up question here on the same question. What about glide of the wrist tendons across the zone of injury?
Yeah, I think glide is, again, really important, but if you think about how far a flexor goes, there's 70 millimeters of excursion at sort of the wrist. Again, if you check my Spice Girls thing, stop and treat finger stiffness first. If someone's doing most of that, they've probably got, somewhere in the order of 50 to 70 millimeters of glide from a flexor point of view. And, in the extensors, you'd be up there in the 50s, 50 millimeters of glide at that zone. So I think for me, it stands in not necessarily fixing what ain't broke. I think it's important, above all, to have tendon glide, but that'll be evidenced by full active digital movement, or it'll be a decent amount. We know when we treat specifically just wrist tendon lacerations that they don't tend to get that stiff, and actually that we know that by the movements of those don't tend to be an isolating factor on their own. But I think a good point. not to be totally ignored.
And Renee Lim asks, do you encourage patients to use heat prior or during stretch?
Oh, yes and yes. I mean, the more heat you can get on, usually for stretch, the better. And you see when you do one of those modified weeks tests, you'll see the difference in movement. And patients often like it with heat. You know, even if they say, oh, but it's hot all the time, it's a bit uncomfortable. Or if it's hot outside, which we don't have that problem as much here. The heat gives you an extra few degrees. How well it maintains over the longer term, I don't know, but sometimes all a patient needs to do is move and feel confident moving and push a little bit further. And that's probably why most people do well on it without complications.
All right, we are at 8 o'clock now. I'll just hand over to Emma to see what the plan is in terms of wrapping up or keep you on going.
Thank you, Brodwen. I'd like to thank yourself, Brodwen and Jeff, for such a comprehensive information session. If we're not able to answer all the questions that have come through, we will respond to the questions outside of the webinar, unless people want to hang around for a few extra minutes. We'll also send everyone an email with your contact details as well if they want to touch base with you directly with any questions. For our attendees, a certificate of attendance will be provided after the webinar for your CPD records. So this now concludes our webinar. On behalf of Performance Health, I'd like to say a huge thank you to Jeff and Brodwen from Upper Limb Co. Such a wonderful presentation. And thank you to all our attendees for joining us tonight. Thank you.
Thank you.
Thank you, everyone.